Um, Welcome to today's tutorial. Yeah, this is Dr. T, and welcome to Clinical Medicine with Dr. T. So today we're talking about spinal anesthesia. So if there is one type of anesthesia, if there is one type of anesthesia that you guys are gonna see, that you're gonna do, is spinal anesthesia. You're gonna see a lot of this, you're gonna do a lot of this, and it's worth knowing it in detail, if I may say. Like I always say, I'm not a specialist, I'm just an intern that has got passionate about teaching. So I don't know everything. I don't think there's anyone who knows everything. But yeah, so this is one type of anesthesia that you guys are gonna be doing all your life, as long as you are still doing general medicine. And also if you go on and specialize, specialists, they do a lot of spinal anesthesia for pregnant women, be it in private or public. Doing a GA is for certain cases. But yeah, so what we know is that spinal anesthesia falls under neuraxial anesthesia. It falls under neuraxial anesthesia, and we know that neuraxial anesthesia is under regional anesthesia. So we did talk about this in my introduction to anesthesia for our very first video on anesthesia. So just to remind you, we said that the types of anesthesia is general anesthesia, is regional anesthesia, and we have got infiltration, we've got topical anesthesia, we've got intravenous regional anesthesia, like Bayer's block specifically. And we said that under regional anesthesia we've got spinal anesthesia. We've got spinal anesthesia, and we have got epidural, and we've got a combination of combined spinal epidural anesthesia. So now we're talking about spinal anesthesia. So what is spinal anesthesia? Basically, you have a patient that you want, so it's actually injecting a local anesthetic into the CSF of the patient, and you inject in the lumbar. We are going to talk about the actual location, but in the lumbar spine, or in the lumbar, around the lumbar vertebrae, whatever word. So the plan is not to inject the local anesthetic into the spinal cord, but you want to inject it in the CSF. So why would you want to inject a local anesthetic into the CSF of the patient at the lumbar vertebral column level? That's the level that is used, the lumbar. So you do that when you want, for the purpose of anesthesia, or for the purpose of analgesia or both. So now, in what operations, let's talk about these two. So in what operations would you want to do a spinal anesthesia? In what kind of operations is a spinal anesthesia indicated? So it's indicated when you are going to do procedures that are in the lower extremities, let me say lower limb procedures, in the lower abdomen, in the pelvis, in the perineum, so when a surgical procedure is going to be done in the lower limbs, in the lower abdomen, in the pelvis, in the perineum, one can consider doing a spinal anesthesia, right? So now, so now let's talk about so we all know that the spine, the vertebral column is like this. Do I still remember how to draw it? So the thorax is like this, and you have your lumbar like that, and you have your coccyx. Then you've got your C-spine there. So this would be our C-spine. This is our T-spine. This is our L-spine. And then you've got your coccyx there, and your sacrum. You've got your sacrum and your coccyx. So this is the area of concern when you are doing a spinal. So if we've got our vertebral body like this, this is our L, L1, L2, L3, L4, L5. So when you do a spinal anesthesia, an ideal location is L3, L4, or L4, L5. And why is that? The reason is that the spinal cord as it runs down, in most patients it's said that it ends around the lower border of L1, like that. That's the spinal cord. So the plan is not to inject the spinal cord, but it's to inject the local anesthetic, which we are going to talk about, into the CSF. So the cord terminates around here, but you continue to have CSF going down up until you get into those I don't remember what they call them now. But what we so as much as the cord ends here, you still have the layers that came with the cord. Your 3 layers, your dura, they go down, they continue to go down, and the CSF continues to be there as well, right? So your 3 layers, your dura, your pia mater, and your arachnoid continue to be there with the CSF. So going higher than these 2 levels will result in the injury of the spinal cord itself. What we always try to do is to target L3 and L4. The space between L3 and L4 is this space. The space between L4 and L5 is this space. This space is deemed or is known to be safe to inject your local anesthetic, right? Now, how do you get that location? Because these are the 2 locations that you want. How do you get them? There's an imaginary line that we draw. So if you locate the iliac crest of the patient, it's gonna be something like this, something like this. Like that. So if you locate the so it's called the superior or the posterior superior iliac spine. So these are your 2 posterior superior iliac spine. So there's an imaginary line that we draw from this. So your first job is to locate these 2 bones, and then you draw that imaginary line. That line, in most patients, it said that it goes through L4, like that, L4. That's why if you go just above this line, you will be in L3, L4. If you go up below it, you will be in L4, L5, right? Obviously, this is your pelvis. These are the bones of the pelvis. And then now you inject your local anesthetic there. So, like I did explain that chances of hitting the spinal cord, they are minimal because it's known to terminate around L1. So by the time you come here, it's just CSF and those three membranes going down. So it's gonna be hard to explain the procedure, how you do it on your video without an actual patient. So I think I will not do that. I'll discuss the other things. So yeah, the issue of sterilizing and training and all those things, I skip them because I feel those are things that one needs to learn next to the patient or on a patient, or say it being done or at the skills lab, right? So that's where we inject our local anesthetic. And we are going to talk about the drugs, but the drugs of choice when it comes to local anesthesia, we are going to talk about them, but it's bupivacaine, bupiva, and we did talk about bupivacaine, that it's an amide in terms of its classification, and it's the commonly used one. But the other, like levo, can also be used. Levobupivacaine, ropivacaine can also be used, but ropivacaine is said to, there's a reason why most people go for bupivacaine. We are going to talk about that later on in the doses and all of that. But for now, let's appreciate that spinal anesthesia, it's a type of a neurological anesthesia, and it's a regional block. And the thing, what we want to is to inject a local anesthetic into the CSF. And the reason why we want to do that is because the indication in terms of surgery is when it's either when you want to give pain, you want to take away pain, or you want to give that local anesthetic purely for anesthetizing. But if you've got a patient that is in so much pain and you want to give them, like for instance, I mean, an epidural, people are given a local anesthetic as a form of an analgesia, so that they can continue with the labor and so they can deliver, minimizing pain. So the surgical procedures that you want to do as per anesthesia is lower limb surgery, lower abdomen, as in the case of C-section, pelvis, and perineum. And like we said, in the vertebra, the location that you want, the level that you want is the L spine that you want, and the actual location is L3, L4, or L4, L5. And the reason is that at L1, just at the border of the lower border of L1, that's where the spinal cord actually terminates. You don't want to fiddle up there because you will injure the spinal cord. So you want to be lower down, and the ideal location is those. And you use your posterior superior iliac spine to locate your L4, and you know that above that line you can go, just below that line you can still go. Let's meet in part 2 of this video. Thank you.